So to wrap up the case and our last presenter, the team does a great job at providing post-op fracture care to Mrs. Tabulum. To ensure that she doesn't return with another fractured hip, I have Carla here from the Fracture Liaison Service, and she will talk about treatment.
Thank you very much. It's so good to see so many people. I think we had the highest registration ever this year, so that's really good. I've been at every single Dr. Burns program with the exception of one. I got taken to see Elton John one year, so I had to miss that one. So it gives me great pleasure to be here and to see all of you here and to remember Dr. Burns. He was the first physician who called me Carla. He was the first one who knew my name, and I'm gonna cry. And we shared a birthday. So yeah, so everything, when we worked on Thanksgiving, we, complained a little bit, but that we were there having our birthday together. So I'm here to talk to you a little bit about my passion, osteoporosis, and you haven't heard that word yet this morning, have you? No. So do you know that 80% of fractures in people over 50 years old are because of osteoporosis? 1 in 3 women and 1 in 5 men will fracture during their lifetime because of osteoporosis. 30,000 people in Canada fracture their hip every year, and that costs us $2.4 billion a year to look after these hip fractures. And all fractures are not preventable, but a lot of them are. Okay, so I'm here to talk to you a little bit about that. So over the next little bit, we're going to talk about the care gap and why it exists. Talk about what a fragility fracture is, look at some of the investigations that we order around osteoporosis. We're going to determine Alice's future fracture risk. We're going to provide some treatment options for her, and we're going to talk a little bit about treatment in those old patients that you look at me funny when I come to see them on the floor. So my first thing that I want to say to you is, did Alice warn us that she was going to come and see us with a hip fracture? Yes or no? Yes. She did. How did she warn us? Absolutely. So the biggest predictor of another fracture is having had a fracture already. And if I had been in Dr. Legay's clinic when she came in with her wrist fracture, we'd be eating lunch right now. We'd be all done. So yeah, as a matter of fact, fractures are the biggest predictor, and fractures beget fractures. So after a fragility fracture of the wrist, we know that 14% of people will come in with another fracture within 3 years. And after a vertebral fracture, which is the most common osteoporotic fracture and often goes unidentified, 20% of people will have another broken vertebrae in their back within 1 year of having that fracture without intervention. And with the hip fractures, this is the scary part, and I'm sure all of you have recognized patients that have come in like this. 9%, or about 1 in 10 people, will come in with the other hip broken within a year. Okay? 20% of people will come in with their other hip broken, so 1 in 5 within 5 years, and 33% of people will come in within 5 years with a non-hip fracture. So we know that fractures are the very biggest risk predictor, and so Alice's previous wrist fractures definitely told us that she was going to come. Now, did Alice know she was going to come? Okay, so Alice couldn't tell us that she was coming really because her osteoporosis was never diagnosed at the time of those hip fractures. So osteoporosis is completely silent. You can't see it and you can't feel it. So you don't, whether a patient has osteoporosis or not, they don't care because it doesn't hurt anyway. It doesn't make, well, unless they've had a lot of vertebral fractures, it doesn't make them look any different, but it does increase their fracture risk. And so that's what I tell them. It doesn't matter that you have osteoporosis. My job is to tell you how at risk are you to break again and to help you to prevent those breaks from happening. So it's definitely a silent thief. It's like high blood pressure. It's not an old lady's disease. disease. So even though Alice is our representative patient here today, men certainly get fractures as well as younger people. So it's important to have those identified. And we miss an awful lot of opportunities to intervene and to prevent the next fracture from happening. I like to call this slide the osteoporosis career of a patient. So, oftentimes a woman will come in around perimenopausal time when she's 56 or 57 with a broken wrist. She'll come back in another few years because she slipped on the ice again and has had another broken wrist. And then she might have a couple vertebral fractures, which may or may not be felt because 2/3 of people are not aware that they have had a vertebral fracture in their back, so they don't know that they've had it. And then she shows up with her hip fracture. Okay, so each time one of those fractures happens is a time that we could intervene and perhaps do something to prevent the next one. And you'll notice that each time the fracture happens, you can see the little curved line that comes up in the bottom. After the first wrist fracture, she gets pretty much back to normal. But with each successive fracture, it's very much harder for her to get back to her normal activities of daily living and her normal way of doing things and living her life. Okay. So about how many percentage of people do you think get treated after a fracture? Do you have a guess for osteoporosis? Oh, geez, I must have been talking an awful lot. So about 20% of people actually get treated for osteoporosis after they have had a hip fracture. So this is a worldwide phenomenon. So of the 100% of people who come in with hip fractures, 20% have their underlying osteoporosis actually looked at and dealt with. If we did this, and somebody's slide, I think it was you, Dr. Legay, you had a slide that said hip attack. So if we did that for a heart attack, it would be criminal, right? If we didn't treat people after they had a heart attack. So we need to treat people after they've had a hip attack as well. The treatment is safe and it's effective, and it can reduce fracture rates by up to some of the medications actually reduce them by 65%. So we can't eliminate the risk for fracture just like we can't eliminate the risk for falls, but we can certainly decrease that risk considerably. So why do you think that we don't treat people? Why do you think people don't get treated for their osteoporosis? It's not sexy, right? It's hard. So there's some theories. There's lots of theories out there. We call this the Bermuda Triangle of osteoporosis care. Okay? So we have the orthopedic surgeon, and Dr. Legay has come in and he has done a wonderful job of putting Alice's hip back together so that she can walk again. And we have the team all around her. So Brenda's got her mobilizing and walking and getting back on with her life. So the orthopedic surgeon, that's his job. That's what he does. He puts the hip back together. We have the osteoporosis specialist down in one corner. The osteoporosis specialist never gets consulted for Alice because nobody ever mentions osteoporosis to her, right? So the osteoporosis specialist isn't going to deal with her osteoporosis. And unfortunately, a lot of the onus goes to the primary care physician. But in fact, especially when you look back at the history, when Alice had her broken wrist, she came in to see the orthopedic surgeon 3, 4, 5 times to make sure that her wrist was healing properly. She's 80 some odd years old. Getting there, she needs to find a drive because her arm isn't working anymore. She's not going to go see her family doctor about that. And when she does go to see her family doctor, she also has her diabetes that we have to look at, and she has her hypertension, and she has all of those other things. So it's not always seen as a priority. Okay, so that's the fracture patient kind of gets lost in the middle of the Bermuda Triangle. And I would like to put I should have had a little picture of me, because that's what the fracture liaison nurse is for, is to bring all of those pieces together and make sure that that patient doesn't get lost in the Bermuda Triangle, and so that her treatment can happen and we can prevent the next fracture from happening. So, did Alice, whoops, I gave you the answer too quick. No, I didn't. Okay. Did Alice break her hip and fall? Or did she fall and break her hip? What's your guess? Yeah, she fell and broke her hip. Okay, so no, she didn't break her hip and fall. She fell and broke her hip. It's very rare to have a hip break spontaneously. Okay, so fall prevention is very, very important. It's about 95% of cases, it's a fall and break a hip rather than a break a hip and fall. So we don't see the break a hip and fall very often. So it's the fall that happens. So we need to do some fall prevention. It's a fragility fracture. So a fragility fracture happens with minimal or no trauma. So it would be the equivalent of a fall from standing height or less at walking speed or less. Okay, and that's what happens when people break their wrists and their hips and their shoulders. You'll see that I have a cough or a sneeze in there. A cough or a sneeze can break a vertebral body in a patient who has severe osteoporosis in their spine. Okay, so those are the spontaneous fractures that we see, but for the most part, the peripheral fractures, you have that fall first that happens. And when I call them a fragility fracture, when I talk to my patients about their fragility fractures, they look at me like I have 9 heads. Because, like you said, Brenda, each one of these fractures is a catastrophic event for them. They've had this fall and they landed really, really hard, and they landed on concrete and they landed on ice or whatever, and if the dog hadn't tripped them, I see more patients that tripped over dogs than anything else. If the dog hadn't tripped them, it wouldn't have happened. They never blame their bone. So when I talk to patients, I say, if you were out shoveling the driveway and you had a heart attack, would you blame the snow or would you think there was something wrong with your heart? It's the same kind of thing. If you're out shoveling the driveway and you slip on the ice and fall down, you got to blame your bone a little bit, because typically a person will not break from a fall from standing height. Okay, so those are the kind of fractures that I see, and that's the hardest part of my job, is convincing my patient that they had a fragility fracture, because it sounds like it's not, and it is very traumatic for them. So fall risk is important, and it's important to address and look at a multifactorial approach to prevent falls. Hip protectors are the evidence on hip protectors goes one way or another way. There is some evidence that in long-term care facilities that they do help to protect from fractures. The thing with them is they have to be on the patient. They can't be in the drawer. They don't work unless they're actually worn. And a lot of times it makes it a little bit more difficult for them patients to get them up and down if they have to go to the bathroom and things. But in long-term care facilities, it does work somewhat for patients who are mobile. Exercise, balance, strength, and functional training. We used to talk a lot about weight-bearing exercises for osteoporosis, but now it's not so much about having osteoporosis, it's about fracture prevention. And we found that the balance exercises and strengthening exercises and functional training actually work a little bit better to prevent those fractures from happening. So that's really important too, along with the weight-bearing exercises. Medication reviews are very important. We want to deprescribe the medications that we can deprescribe. Environmental hazards we talked about, and Brenda's already taught Alice to use her assistive devices correctly. I saw a lady the other day, she was walking down the hallway and she had her walker with her, and she was on the outside of her walker with one hand on the walker, just bringing the walker along with them. So, you got to use them the right way too. And management of incontinence. Those are some of the key contributing factors to falls. And like Brenda said, we can't prevent all falls. So if we make the bones a little tougher, those falls might not cause the break to happen. So what are the risk factors that Alice has presented with that are going to contribute to her fracture risk? Okay, so these are the kinds of things that I look at. Her age, she's 83. I include her height and her weight in my risk assessment. Her fracture history is very important. So she's had 2 wrist fractures and a hip fracture. Okay. Her mom fractured her hip when she was 76 years old. Alice doesn't smoke. She doesn't take steroids or glucocorticoids. She doesn't have rheumatoid arthritis. This is good. She does have diabetes, though, and a history of diabetes, even type 2 diabetes, of longer than 10 years actually increases her fracture risk. And she doesn't consume significant amounts of alcohol. So when I get all that information when I see the patient, I plug it into a formula, and that's called the FRAX tool. FRAX is a risk predictor tool that is used all over the world. It's been proven to be very accurate. It's different based on which country you're in. So if you're going to FRAX somebody, you have to make sure that you've selected the right country. So what I do is I plug all of Alice's data into the tool, and it will come up and it will give me a percentage. Okay, you'll see that I did check off rheumatoid arthritis there at the bottom if you have really, really good eyes, even though she doesn't have rheumatoid arthritis. They have found that the diabetes actually fits under rheumatoid arthritis better than the secondary osteoporosis, so that's why that's in there. And it gives me a percentage. Okay, so Alice is 47% at risk to have another fracture within the next 10 years. Okay? Unfortunately for Alice, this actually isn't accurate, okay? Because Alice, if she had had one wrist fracture, that's what her risk would be, okay? Just one. So we already know that she's had 2 wrist fractures and a hip fracture, so her rate of fracture is probably going to be even higher than this. So for this patient, I wouldn't even use the FRAX tool. Alice is automatically at high risk for future fractures. Okay, you'll see I did plug in her bone density score there as well. So regardless of what FRAX tells me, we know that she's at high risk for future fracture and she needs to be initiated on an appropriate osteoporosis therapy to reduce that risk from happening. So the other thing that I do is I organize all of the investigations that need to be done to get that patient started on medication. And you'll notice when I see Alice, I don't always order a bone density test. And the reason why we don't order a bone density test is because we already know that she's at high risk. It's not going to change her diagnosis. It's not going to change the fact that we know that she needs to be on medication for her bones. So she doesn't need to have a bone density test. She also doesn't need to have spine x-rays. That's another thing that we order just to see if there are any of those vertebral fractures in her spine that we're not aware of. So that bone density test and the x-ray, that's not going to prevent another fracture. Only the medication will prevent another fracture. Now, sometimes I do order them because they do serve a useful purpose as a baseline. Okay, so after the patient's care gets transferred back to the family physician, if the family physician is going to monitor the treatment, we would want a bone density test now, and then we want another bone density test in a year or so to make sure that the bone density hasn't dropped. We don't expect to see it go up, but we don't want it to get any lower. So it does provide a useful baseline. So usually when I see patients in the hospital, if they're 87 years old, I don't order a bone density test, but if they're 65 years old, then I do, because they tend to be monitored on a longer term basis. We do some routine blood work. The routine blood work that we do is important because we need to know that it's okay for Alice to be able to take the medications, okay? So it makes sure that her body is, able to tolerate the medications. And it also looks for secondary causes of osteoporosis. So we want to make sure that the calcium level is high enough, and we use the ionized calcium because the medications are not to be given if patient is hypocalcemia. If her vitamin D level is very low, it can precipitate hypocalcemia. So we like to see the vitamin D level at least at 75, and if it's a little higher than 75, we're happy with that. So vitamin D level is important. The meds can be started with it a little bit lower, but denosumab, one of the medications we use, actually you really want that vitamin D level to be normal, and the zoldronic acid as well. We want to look at TSH because hyperthyroidism will increase her fracture risk. The EGFR, we want to look at her glomerular, I'm not even going to say it. Her EGFR has to be above 30 for her to take the oral bisphosphonates. So that's why we check that. We look at ALK-Phos, which can show hypophosphatasia. And in vertebral fractures only, we do a serum protein electrophoresis to assess to see if the patient has multiple myeloma, because for vertebral fractures, that sometimes is the cause rather than osteoporosis itself. So Alice's blood workup turned out pretty good. Okay, her calcium is okay. It's all right for us to start her on one of the osteoporosis medications. Her ALK Phos is up a little bit, but that can happen after a fracture anyway. Her EGFR is at 60, so she's well above the threshold to tolerate the bisphosphonates. And her 25-hydroxy-D is at 40 nanomoles per liter, so that is a little low, but it's probably still safe to start the medication. And her CBC is okay. So as Jen talked about, Osteoporosis Canada guidelines, we generally recommend 800 to 2,000 international units of vitamin D3 daily. If a patient is already on a multivitamin, we just add 1,000 to that because they're going to get close to that number. And we know that we need to optimize the vitamin D to make sure that it's safe for them to have the medications. The calcium, we don't recommend calcium pills anymore. It's best obtained through diet. So what I usually tell my patients is you need 3 servings of dairy a day, and that will give you enough calcium. So I don't get too fussy about it. A calcium pill never prevented a fracture. So we just want to make sure that they have it in their diet. It's better tolerated that way. And protein, of course, is very important for the bones. As Jen talked about, it's important for everything. So we want to make sure that, that she gets enough protein in her diet to make that muscle mass around her bone more protective if she does have another fall. So that's sort of the baseline lifestyle treatment that I talk about. And then we recommend medications to get started for her to prevent the next fracture from happening. There's not a ton of osteoporosis medications that we have in our handbag to be able to use. And the most common ones are the oral bisphosphonates, so alendronate or risedronate. And you can see when you look at the chart that each of these medications are effective in reducing the risk of fracture for vertebral fractures, for hip fractures, and for non-vertebral fractures, which includes the wrist and the shoulder and the hip altogether. Okay, so the main ones that we use are the oral bisphosphonates or denosumab, which is an injectable medication that can be given for twice a year for patients. The raloxifene, estrogen used to be used. It's a very good, actually, for preventing fractures, but because of the other risk factors that come along with estrogen, we don't recommend that for osteoporosis treatment anymore. However, if a patient happens to be on it because of other reasons, then it is effective in reducing fracture risk as well. So we have success. Alice has been ordered 70 milligrams of alendronate PO weekly, and it was started in hospital by our nurse practitioner, Kim, or by the orthopod who did her surgery. So this is good news because we know that we're on the road to making sure that Alice doesn't break again. The medication does take approximately 6 months to a year to work, so it's important to get them started as soon as possible. And there is not a lot of evidence to demonstrate that it slows down on fracture healing. So it is safe to start within the hospital. So now that we have the medication started, the next biggest challenge we have is how to give the medication and to make sure that it is given appropriately. So how do you give a bisphosphonate? Sitting up. I just heard ball. With water. Empty stomach. Before food. Okay, we know there was a study done in Hamilton in a long-term care facility. 52% of the RNs that worked in the long-term care facility did not know how to give a bisphosphonate correctly. Good one. So people don't generally know how to give the bisphosphonates correctly, and patients don't understand how to take the bisphosphonates correctly. So lots of times I see patients in clinic. I had one lady, it's just a story. She came in and she had a fragility fracture of her shoulder. She was already on alendronate for her osteoporosis, and I asked her to describe for me how she took her alendronate. Well, I get up in the morning and I take it with my cranberry juice and blah, 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 and she goes on. And this lady had sort of a little bit of baseline dementia coming in. So I said, no, you can't, it doesn't work. It doesn't work. You can't take it that way. It has to be with water or else it's not going to be absorbed. So we had this whole conversation, spoke to the daughter, gave them written information, told them how to take it. A year later, I saw the same lady back with her other shoulder broken, and I went in and I said, how are you taking your bisphosphonate? Well, with cranberry juice in the morning, blah, blah, blah. So it doesn't work. It's like they're not on it if they're not taking it properly. So the education around how to take it is very important. And we had a meeting of fracture liaison nurses from across the country in May in Toronto, and every single one of us had the same problem. So it's trying to get people to know how to do it properly. So we've created this wonderful tool to be posted in med rooms. So we have a tool for nurses as well as a tool for patients to use so that they actually give the medication correctly. So it has to be first thing in the morning, okay? It has to break their fast, and it cannot be administered with other medications. Now, how hard is that? Because you guys have your morning meds to give at 7:30 or 6 o'clock or whenever you give them. This one has to go alone. So even if they're on Synthroid, it has to go an hour before the Synthroid. So we want, well, half an hour to an hour. The closer to an hour we can get, the better. So it has to go down alone. As soon as you put something else in there, the absorption is stopped. It has to go with water. The cranberry juice ain't going to cut it. It can't be with tea. It can't be with coffee. It can't be with any of those other things. And what's very frightening, in that same study that I talked about that happened in Hamilton, there was a good percentage of staff that gave the oral bisphosphonate and let the patient lie back down after they had it. And that's very difficult to control, but it's actually dangerous because if the medication goes back into the esophagus, it can cause some perforation, it can cause some bleeding. So it's actually very dangerous for the patient if they lie back down after they have it. So it is vital that they don't. And sometimes that's a reason to give them parenteral drugs instead of the oral ones, especially patients who are in early dementia, because they can't remember to take it once a week, for one thing, and they can't remember how to take it properly. And they'll get up in the morning and they'll take their pill and go back to sleep. So sometimes that's a good argument to maybe use the subcut or the IV infusion to treat them. The other thing about the osteoporosis drug, it is the side effects from the osteoporosis drugs they're talked about more commonly for an uncommon side effect than any other drug that there is. So that's the other thing that I hear a lot from my patients. Well, my thigh bone is going to break or my teeth are all going to fall out if I take this medication. So they're worried about osteonecrosis of the jaw and atypical femur fractures. When you look at this, the risk of osteonecrosis of the jaw is 1 in 100,000 people. It generally happens in patients who are on the medications because of cancer and they're getting higher doses. And by definition, it is an open to the bone area in the mouth that doesn't heal for 8 weeks. So if somebody has a little jaw pain, that's not osteonecrosis of the jaw. So 1 in 100,000 people, whereas your risk of fracture is 1 in 5. Okay? The other thing is the atypical femur fractures, and we do see atypical femur fractures, and it is a side effect of the osteoporosis medication. But the risk-benefit ratio, the risk of an atypical femur fracture in the first 2 years after being on a bisphosphonate is 2 in 100,000 people. Your risk of a regular osteoporosis break is 1 in 5. Okay? After you've been on the bisphosphonates for several years, that risk does go up to 78 in 100,000 people. Okay? A lot of times, the atypical femur fractures that we see, they should never have been put on the bisphosphonate in the first place, because a lot of times patients get started on this drug because their bone density is a little low and they haven't had a comprehensive fracture risk assessment done. So we don't base treatment just on what the bone density score tells us. We base it on all of those risk factors that I told you about that we plug into the fracs. And you can have a fairly low bone density and still not need to be on the medication. And so that's sometimes why we see the atypical femur fractures. So really, patients patients they're as likely to be murdered as they are to have osteonecrosis of the jaw. So the risk is very, very small for these side effects, but it tends to be a big argument for not going on them. So here's a very poignant question. Is there an age at which we should no longer offer treatment to Alice? Yes. I hear yes. Actually, no. As long as the predicted life expectancy is greater than a year. Okay, so we do recommend that the patient gets treated. So when I come up to see Guy, and you guys are rolling your eyes, because I know you are, and you know, she's 94 years old, Carla, why are you coming to see her, right? I know you're rolling them, I can feel it in the background. But as long as the patient's predicted life expectancy is longer than a year, it is important to treat these patients because our medications work fairly quickly, and if we can prevent the fracture, then if you're going to live a year, you want to live a good year, right? You don't want to live a bad year. So we know that as patients age, the risk of fracture goes up higher, okay? So you can see along the graph there that in the black line that the women, they tend to increase their fracture risk around the, I know what you mean about not being able to see here, Brenda. So and they start, you know, around in the 50s and the 60s, and then it continues to climb. So the older the person is, the incidence of fracture goes a lot higher. Men start a little bit later, okay, so there's a joke there, but I'm not going to use it. Men start a little later, so their fracture risk goes higher a little bit later, but they do actually get to high risk. So the incidence of fractures is very high in our very elderly population. So if they're that old, are they going to live very long? So when we looked at some of the remaining life expectancy of patients in studies in the States, we know that if a patient lives to be 80, if a male patient lives to be 80, he's going to live to be 88, probably, on average. We know that if a patient's 90, they're going to live to be, you know, a lady would live to be 95. If somebody makes it all the way to 100, then they've got another two or 2.5 years left on average. So that means that, you know, you've got some patients who are going to die tomorrow because they're 100, but you've got some patients who are going to live another 7 years, right, to get that into the average. So the population is living a lot longer, and the older they get, the higher their risk is to break again. And we know that our medications work fairly quickly. So when you look at this chart, I wish I had a pointer. Usually you can have the little mouse thingy to work, but this is for denosumab, and they've done some studies on denosumab, which is the injectable every 6-month drug that we use. And you can see that the fracture, the placebo is on the top and the medication is on the bottom, and the fracture, it's looking at fracture rates. And you can see that the fracture rates really start to get decreased by around 6 months. You can see the line starting to separate, and they're working very well by a year. So even though that patient is very old, the incidence of fracture happens a lot less if we do treat them. And I work with, as you know, Dr. Theriault, and Dr. Theriault says that the medication is actually palliative. And it does tend to be one of the medications that gets discontinued very often as patients get older. But, you know, my mom has dementia, and she's in the hospital. I'm telling you, if she broke her hip, I wouldn't want her to break another one, even though she has dementia. And the patients who tend to be treated the absolute least tend to be the patients who have dementia, and the patients who have dementia are at the highest risk of refracture. So it's worth it, even though they are old. And in fact, Osteoporosis Canada, in partnership with a whole bunch of other organizations, has guidelines around the treatment of patients in long-term care. And these guidelines were validated with patients and family councils themselves. And most patients would want to be treated in this situation. A few wouldn't, but most patients would want to be treated in this situation. I know that EGFR, creatinine clearance, is an issue a lot of times in older patients, and denosumab is a medication that we can use in that case as long as it's monitored carefully with calcium levels a couple weeks before, or before the injection and a couple weeks after. So we do have viable medications that are able to be used in older adults. Also, the vitamin D is very important in making sure that they get the calcium in their diet. that just kind of goes through the recommendations there. Okay, so what I do as the Dartmouth General Fracture Liaison Service, I've identified that Alice has come in with a fragility fracture, so we know that this is an osteoporosis break. I've ordered the medications to ensure that that it's safe for her to be able to take medication and to rule out any secondary causes. I've ordered a baseline BMD and spine x-rays for Alice because she wanted them and because she is healthy, generally speaking, and her doctor would perhaps want to monitor her on an ongoing basis. I determined her fracture risk. I've made recommendations to the family doctor for treatment. This is the biggest thing because I'm a nurse, I can't order the medications, so my practice is all about communication with the family doctor and closing that Bermuda Triangle so that the family doctor is aware, and I try to have everything ready for them as much as possible. I fill out all the pharmacare forms, I send the guidelines to make it as easy as possible to initiate the patient on treatment. I spent a lot of time with Alice so that she knows how to take the medication properly and that she understands what her fracture risk is and that she has my phone number and she can call me, and I follow her for a year afterwards to make sure that things are going okay and that she's taking her medication properly and to see if she has any questions. As I said, we communicated all this to her primary care provider as well. So the consequences of a hip fracture, a fracture begets a fracture, right? So there's always a deterioration in the quality of life. And after somebody's had a hip fracture, 40% of people will not be independent in their mobility anymore. They will require ambulatory aids that they never required before, or they will require help with doing things. They previously did their housework and cleaning, and now they need their daughter to help them do that, or their son, and they can't get around anymore on their own. About 20% of people will go directly from hospital to long-term care. There's been studies done that say 80% of women would rather die than go into long-term care and lose that independence. Okay, so 20% are going to go that route. And 23% of women and about 37% of men will die within the first year post-fracture. So it is important to prevent the next fracture. We can't prevent all of them, and sometimes the medications don't work, just like any medications don't work, but we can prevent a lot of the osteoporosis fractures that happen, and that's why it's so important to identify them. So, in conclusion, sorry. I know, but I'm never finished. Alice has received the absolute best practice care for her hip fracture, starting with Dr. Legay and moving through Dr. Von Maltzen and looking with Brenda with her physiotherapy, and with Cecilia and Sheila giving her the very best nursing care, and Jen has identified all her dietary deficiencies, and she's going to go home with a great plan to maintain her weight afterwards, and she's started now on her bisphosphonate, and we're really hoping that she doesn't come back. So I just want to recognize that everybody in this room has a part to play, and even though we don't have OT here and we don't have pharmacy here and we don't have some of the other players that get involved, everybody is involved in making sure that Alice gets the best care when she's in the hospital and that she goes home as safely as possible and hopefully doesn't come back to see us again. So thank you very much.